Good evening, all. Myself, Dr. Amit Jadhav from Bayer Medical Team. Uh, Today we have with us Professor Maha Hussain, ma'am, who will be international speaker for today's session, and we will be taking us through the discussions on the metastatic hormone-sensitive prostate cancer, as well as the what treatment paradigm has been changed since a decade as well as since 8 decades long. And followed by that, there will be a session by Dr. Datatre, who will be giving us a perspective from India. And followed by, there will be Professor Hussein's session, touching upon the treatment paradigm as well as treatment decisions on which background we are setting these things. So today's faculties, we have Professor Amit Joshi. Sir is the professor and head Tata Memorial Center, Advanced Center for Treatment and Research Education, Actrek, Mumbai, India. Professor Mahussein is the Professor of Medicine, Division of Hematology and Oncology, Deputy Director, Robert H. Lurie Comprehensive Cancer Center, Northwestern University School of Medicine, Chicago. Dr. P.S. Dattatray, sir is the Chief Medical Oncologist at KIMS Hospital as well as Reno Hospital, Hyderabad, India. We have esteemed faculty from United States of America, Professor Maha Hussain. She is the Genevieve E. Tuiten Professor of Medicine, Northwestern University. This is the important achievement or degree in terms of in the field of medicine. Deputy Director, Robert L. Louis Cancer Center. Leader in the genitourinary oncology program, practicing oncologist specializing in the genitourinary cancers. Former chair for SWAG as well as the FDA Oncology Drug Advisory Committees. Authored around more than 350 scholarly articles and book chapters in the field of oncology and medicine. She has been awarded with the Prostate Cancer Foundation Award, Women in Science Lifetime Achievement Award in the year of 2025. She has been part of many landmark trials which led to the FDA approvals like enzalutamide, darolutamide, olaparib in the genitourinary cancers. And she has been involved in the novel therapeutics in prostate and bladder cancers. So today's agenda will be there will be context setting and objectives told by the Professor Amit Joshi, followed by the session on the Indian patients of MHSPC. Who are we really treating in India, which will be taken by Dr. P.S. Dattatray sir. And there will be shifting paradigm and what the aeronaut recently approved aeronaut trial will tell us about the MHSPC management, which will be taken by the Professor Mahussein, and subsequently question and answer from across India panel. So with this, I would request Dr. Amit Joshi sir to set the context for today's meeting and take us ahead the program. Over to you, Dr. Amit Joshi sir.
Thank you, Dr. Amit. So I think it's my privilege to having a discussion or having a board, Dr. Mahausen, which we have read many papers about prostate cancer related work. So it's our honor to her on this board. So just to before starting the context, the purpose of today's meeting is to share and understand the unique epidemiological aspect and clinical characteristic of Indian MHSPC. So what we see in the Western world, definitely we see a different patient profile in Indian patients. So what are the differences if compared to the Western world? And also to discuss about the data which is available in form of Aeronet, that can the ADT plus darolutamide is one of the option in the management of MHSPC, especially the low volume, and in the context for other associated molecules like enzalutamide and abiraterone, where does the darolutamide fits into the arena of the low volume metastatic prostate cancer, and to also look about the global trial data and compare to the real world consideration. When we see the patient, we know that whenever we see patient in the OPD, all patient will not fit into the real clinical trial patient. We have to make some adjustment as per the local patient general condition, patient's financial aspect, patient's other comorbidity. So how this will be integrated in the management, that we discuss. And definitely in the last, and to apply the evidence based criteria for selecting appropriate ADT based doublet or triplet regime. So compared to the western world, where majority of the metastatic prostate patients are diagnosed in a non-metastatic scenario, is still in our country 60 to 50 to 60% patient are still diagnosed in a metastatic scenario. So compared to the western world, we have still a large volume of a MHSPC compared to the west, where majority of the patient will be diagnosed in a in a non-metastatic scenario, then they will convert into NMCRPC, and then will go into the MHSPC. So the patient presentation is little bit different compared to the western population, and the patient's profile of a de novo metastatic is much more common than the metachronous. So synchronous is much more common in our scenario compared to the western world. And then definitely the treatment options what we discuss in our scenario, that, and these are the slides which we have seen multiple times, that how the treatment. So I think the opening of this management scenario was ADT plus docetaxel, the charted trial, and then came the stampede trial. So doublet era has started in 2014, and in last 12 years we have crossed a long journey, and we know that in the current era, in a metastatic scenario, ADT alone is not the standard of care. Either some sort of a ARPI or a ARP plus docetaxel has been. So in 2024, if you look back, the journey started in 2014, and in 2024, the treatment paradigm had changed, and ADT plus ARPI or ADT plus ARPI plus docetaxel is the current standard of care. So how this has changed in Indian patient, that definitely we will discuss. Dr. Dattatreya will take into the Indian MHSPC scenario in this patient. Thank you for patient listening.
Yes, Dr. Dattatreya.
Yes.
Yes.
So thank you so much for making me a part of this international speaker program, Prime Meet 2026. And Amit has set the context. Let's look at the Indian patient of metastatic HSPC. Who are we really treating? I'll end up with four sections. The reality in India, who
Yes.
is the Indian MHSPC patient, what about the India versus the global guidelines, and what this means for our clinical oncology practice. Next slide. So in 2022, we had close to 38,000 new prostate cancer cases, of which 43% already had distant metastatic diagnosis. Now, the median age is between 64 to 66 years, which is younger when compared to global. It's around 72 to 74 years. The disease most often in the Western countries is screen detected, whereas by and large, it's only when some symptoms start appearing, and usually, even in this age group of 64 to 66 years, there would be some higher comorbid conditions. Next slide. So essentially, while we talk about overdiagnosis, overtreatment in the Western population, we here talk about underdiagnosis and undertreatment. More so, 80% of patients are stage 3 or 4 at presentation. The proportion of this advanced stage is higher in the younger age groups who are less than 50 years in the Indian population. So that, I think, is a stark reality which tells us that a lot can be done with regard to the proper implementation of screening to identify these patients early on. Next slide. So why is India diagnosing so late? Five principal reasons. Low awareness, screening is absent for PSA, not a part of national screening programs. There seems to be some stigma with the urology symptoms, and so it ends up in a cultural silence because these symptoms are thought to be old age, and therefore they remain unattended to for months and sometimes years. Third, limited access to specialists because the urologists, the oncologists, and the uro-oncologists are usually found more in the urban centers. When compared to tier 2 and tier 3 centers, cities and in the village areas. And that's why sometimes even PSA testing is not appropriately performed. Forget the biopsy and staging imaging. Fourth is referral delays, and more than that, bottlenecks like administrative delays at public hospitals lengthen the diagnostic journey. And lastly, limited reimbursement, which means access barriers. If you look at the demographics, who is the Indian metastatic HSPC patients? 90% of them, 80-90% of them are de novo metastatic. 90% fortunately are at presentation fit, ECOG PS 0 to 1. 90% have some urinary symptoms, and that's what I meant, that very few are screen detected. 90% of them high volume disease with looking at the charted criteria. 70% are Gleason score 8 or more, high grade disease diagnosis. Close to 80%, 90%, at least one comorbid conditions. 40% could have two or more comorbid conditions. On the other hand, if you look at the benefit of, say, for instance, this study looking at, do Indian men have similar outcomes with abiraterone with NDT when compared to the Western population, we find that the reduction in the risk with regard to the OS is 28% in this article by Mandal et al. In 2024, which is something like around 10% less when compared to the Stampede and the Latitude Western data. AA plus spread does with ADT does improve the PSA response, radiographic PFS, but however, there seems to be a gap, and the reason why this gap is because of later stage entry, higher treatment discontinuation, fewer subsequent treatment lines, and less access to image guided dose modifications. So, this possibly is the reason why we have this gap when compared to the Western population. ADT monotherapy becomes the most common treatment. Doublet therapy, I firmly believe, is in majority of the tier 2 or 3 cities underutilized, though that's not the case in the metropolitan cities. Triplet therapy is a rarity in in tier 2 and 3, so again used more commonly in tier 1 cities and in the metropolitan cities. The treatment discontinuation is also significant. A substantial proportion of patients discontinue mid-course either because of poor tolerance or because of existing comorbid conditions. But by and large, monotherapy seems to be the most common treatment, predominantly in the tier 2 and 3 cities. And that's why overall it seems that the ADT monotherapy becomes a most common treatment. But this means for our practice four important implications. Next slide. The Indian HSPC patient is younger, has de novo high volume disease in 80-90% of patients. Fortunately, 90% of ECOG PS 0 or 1. They are biologically eligible for intensified treatment despite comorbid conditions. Triplets can be done, as we all know, but underutilized. Even doublets are underutilized. 40% of Indian prostate cancer patients have distant metastatic disease, a rate is five-fold higher in Western countries because of delayed screening, social stigma, culture stigma, and access barriers. We know that ARPI plus ADT improve survival, but outcomes remain poor. And that was one trial data I showed you about the abiraterone ADT combination when compared to Western population, driven again by late presentation and higher discontinuation. And so I would like to put the bottom line, there is a need existing for evidence-based treatment intensification for driving a real-world evidence generation and to improve the OS and quality of life. On the other hand, we have to optimize strategy and access to care in India. Thank you so much. And with that, the stage I think is set for our international faculty to guide us about darolutamide and all the advances. Thank you so much.
Yes, Professor Hussain, over to you.
Okay, thank you so much. So I want to thank Dr. Jadav and the organizers for the invitation. Please let me know if you are able to see my screen.
Yes, they are
Okay,
visible.
great.
Yes.
Okay, great. So my discussion with you will focus on the therapeutic landscape of metastatic hormone-sensitive prostate cancer and how we have evolved since we started the treatment of this disease. So the historic perspective, I'm going to begin with a very brief historic perspective. Some of you, if you've heard me speak before, you might have seen it, seen these slides. I do think it's very important to learn from the history, which helps us guide future development. So it's interesting that Higgins and Hodges actually reported in the 1940s their seminal observation that prostate cancer is an androgen-driven and dependent disease, and that surgical or medical castration can induce significant regression of the disease. And they actually identified one of the first biomarkers in oncology, acid phosphatase, as a biomarker for this disease. They clearly have noted that essentially, and since then, the data indicate that the high percentage of patients will respond to androgen deprivation, but then the majority will end up progressing with a median survival of 2.5 years. Since the original observations and the implementation of orchiectomy really decades ago, we've seen, as you see here, significant progress in the management of this disease, moving into from surgical castration to medical castration, the identification of androgen receptor inhibitors, so peripheral blockade, therapy intensification with chemotherapy, with combined androgen deprivation, with the first AR inhibitor being flutamide, bone-targeted therapy, concept of intermittent versus continuous therapy to enhance the sustained responsiveness to androgen deprivation of the disease. And since 2015, we have really entered a whole new era of therapy intensification with the introduction of docetaxel as part of the doublet treatment, and then other AR pathway inhibitors as highlighted in here, abi, pred, enzalutamide, apalutamide, darolutamide. And then we have entered the era of triplet treatment, which I will be discussing with you. And now that we have the PSMA, lutetium PSMA treatment, this is also currently is an area that is being investigated, and I'll show you the data. This is just a summary of the older combined androgen deprivation trials. This is, again, the idea here is to maximize the androgen deprivation by not only suppressing gonadal production of testosterone, but also by blocking the androgen receptor so that any other extragonadal androgens can be blocked from reaching the cell. And as you see here, all of the trials that were done, whether it was orchiectomy or with LHRH therapy, you see that there was a median survival improvement of about 6 months or so for the combination treatment. Now, one of the first prognostic factors that were identified actually dates back to the older SWOG trials that evaluated androgen deprivation plus flutamide. And there they observed, it was post hoc analysis, observed that patients who had what they called minimal disease, specifically in the axial skeleton, or pelvis or lymph nodes, did better than those who had appendicular skeleton or visceral disease. This was also verified in my intermittent trial, which we reported. Now, the MD Anderson group had a different definition of higher risk disease there, and based on the number of lesions and also the visceral disease. And so when the CHARTED trial was designed, which was the first trial to demonstrate the advantage of adding docetaxel chemotherapy to androgen deprivation, there was a hybrid definition of the disease volume there using the SWOG and the MD Anderson data. And a high volume disease was defined as patients who had visceral metastases or 4 or more bone lesion with at least one of them is beyond the axial skeleton and pelvis, specifically the vertebral bodies and the pelvis. Now, of note, I should point out that basically when the CHARTED trial, when we designed it actually, this was stratified with the patients based on disease volume. Interestingly, The patients who benefited from the addition of chemotherapy, the docetaxel chemo, was actually the high volume patients. The low volume patients did not seem to benefit. Now, since then, we have seen really a significant progress in the field. And this is from a publication that we published in 2024, summarizing the history of doublets that are life-prolonging in prostate cancer. So aside from chemotherapy, as you see here, the different clinical trials that were done evaluating abiraterone, prednisone, enzalutamide, apalutamide, all of these actually demonstrated overall survival advantage. And since then, the aeronaut actually was reported and published, again, demonstrating overall benefit in overall survival and progression-free survival, looking at the different subgroup analysis as you see highlighted in here. Now, one of the things with, I think, the advantages with the darolutamide is that what you look at it in terms of the combination with androgen deprivation, that essentially the benefit was consistent across all the group, as you can see here with the subgroup analysis. Overall, practically everybody seemed to have responded, irrespective of age, how high their PSA was, functionality, region, and so on. And this is actually, when it comes to disease volume, as you see here, there was definitely a benefit in both high volume and low volume patients. Now, overall, the treatment was very well tolerated, and there's not that much difference in terms of the adverse events as it relates to the control arm. There was actually lower discontinuation rate with darolutamide. And what you can imagine, this is because you're getting a better disease control overall, and the agent is well tolerated. Now, we have entered the era of triplet therapy, and one of the first triplets that were reported is the PEACE-1 by Dr. Fazazi and colleagues. And this was a trial that basically part of a trials, the PEACE trials that they have, where patients were receiving androgen deprivation plus abiraterone prednisone, and they looked at the subset of patients who actually had chemotherapy also. And what you see here overall, there was an advantage in the addition of the triplet therapy compared to the doublet, but interestingly, they did a post hoc analysis by disease volume. And what you see for sure that the benefit in the high volume patients is there. The low volume patients, you don't see as much difference. However, it's a bit, the data is not mature yet at the time of the report. And as you can see, the median was not reached. The second triplet is the Enzamet. And this is primarily Australian type based trial, but also other sites. And what you see here in this particular trial, the overall survival with the addition of enzalutamide added advantage. This is the subgroup of patients that had the docetaxel. And what you see basically, definitely, there was an advantage in the triplet treatment. And when they looked at synchronous versus metachronous, what you see, the bulk of the benefit was in the synchronous, which is not a surprise because these are patients with de novo metastatic disease. The median was not completely reached yet otherwise, but there is benefit in both low volume and high volume patients. And for the other trial that I was had the privilege of being part of the steering committee and who designed this study is the ARASENS study. The ARASENS is a randomized phase 3 clinical trial in patients with metastatic hormone-sensitive prostate cancer, which basically randomized patients to triplet with darolutamide, docetaxel, and androgen deprivation versus doublet with docetaxel and hormone therapy with a placebo. And basically what you see here, there was a significant improvement in the overall survival with the darolutamide triplet treatment. When we looked at different criteria, radiographic progression-free survival was better, overall quality of life and so on were much better. Now, one of the things we did is the whole idea was to look into whether there was an advantage in the triplet versus doublet based on the disease volume. And I would remind you that the doublet in this trial is not an AR inhibitor, but docetaxel. And so what we looked at is the definition by the high volume disease based on the charted criteria, and the high risk disease by the latitude criteria. And what you see here is basically, irrespective of the criteria that we use, there was definite improvement with the triplet treatment in high volume, high risk disease patients. I want to point out that it's very fascinating that of the patients, all the patients that were enrolled in the ARASENS trial, the majority of the patients, 77% of them had had high volume disease, and 70% had high risk disease also. And so this is a very sick group of patients, or aggressive disease group of patients, and yet you see the benefit across the spectrum of these, which is really very encouraging. Now, one of the prognostic factors aside from disease volume is the nadir PSA. So the nadir PSA as an undetectable, or the PSA decline, clearly the undetectable PSA is sort of like the benchmark. And this was the first report I reported from the original intermittent trial, SWOG 9346, where we identified nadir PSA at 7 months to be very strongly prognostic when it comes to overall survival. This was then validated and actually confirmed in the Latitude trial, in Charted, in the ARASENS also, and in the Titan trial. So that's a very strong biomarker. One thing I should caution you about is that don't use it by itself without actually confirming with imaging, because in the discussion, I can share with you some recent experiences we're getting with transformation of the disease. So definitely, I would say this is a good and simple blood test to monitor the disease responsiveness, but definitely combine it with periodic imaging also. Now, one of the things is from the darolutamide, and this is from the trial that looked at the doublet with darolutamide. As you see here is also PSA. Significant percentage of the patients, more than 60%, actually achieved the PSA undetectable range, and then time to PSA progression was significantly delayed compared to the control arm. And this was actually seen both in the high volume patients, where there was a high rate of undetectable PSA, and then delays in time to PSA progression, and then overall survival, clearly strongly pointing to the benefit of the combination treatment. Now, this one and the low volume also, as you can imagine, this is not surprising. The low volume patients tend to respond also very well, clearly better than the high volume, but still this is very critical benefit from the ARASENS. Okay. Now, one of the questions I think that comes up is obviously the issue comes up is how best to choose treatment for patients. And clearly, one size does not fit all. And so, one size does not fit all. And this is multiple factors have to be taken into consideration. The age of the patients, the health status, comorbidities, the genomic profile, I think, has implications potentially for therapy choice. The cancer characteristics, is it de novo? Is it high volume? The aggressiveness of the disease? Is it safe to give the patients? Other factors relate to drug-drug interactions and things of that sort. And clearly the patient's benefit. And I think the patient preference, the critical part is we would have to advise patients about what we think is their best choice is, discuss why this a triplet versus doublet is what we're recommending for them. And ultimately, it's going to be a shared decision. Clearly, a big factor that is affecting access to the agents and availability of insurance and costs and other factors. Now, we've entered the era of personalized therapy, and one of the questions is where's best to personalize therapy? And so this is work from the University of Michigan team led by Dr. Earl Chinayan. who basically led the original effort with the Stand Up to Cancer that identified the genomic profile of metastatic castration-resistant prostate cancer. They reported additional data from patients with not only castration-resistant disease, but de novo metastatic disease, recurrent, metachronous metastatic hormone-sensitive disease, and localized disease. And what you see clearly here is that the castration-resistant stage of disease is very more complicated when it comes to the genomic profile. So consequently, it would be simpler to potentially can get a better outcome by approaching the earlier stages of the disease with targeted agents. So there are now several ongoing biomarker-based phase 3 clinical trials that are evaluating PARP inhibitors. This is Talapro, Amplitude, and then the Capitello evaluating the P10 deficiency there with capivasertib, and then the PSMA addition evaluating lutetium PSMA in there. So this is the data that was reported at ASCO last year by Dr. Attard on the Amplitude trial, which evaluated niraparib and abiraterone and prednisone for metastatic castration sensitive, as they call it. I should say I favor the terminology of hormone sensitive, and I'm happy to answer why I would favor that language in patients with HRR mutation there. And as you see, this is a trial design, and this is patients who were castration sensitive or hormone sensitive and had one or more alterations in the HRR genes, homologous recombination repair genes, as listed in here, good performance status. They were allowed to have been on other AR pathway inhibitors. Also, they were allowed to have had prior chemotherapy as part of management of hormone-sensitive disease. And the patients that were pre-selected based on their HRR mutation, they were randomized to niraparib and abiraterone and prednisone and ADT versus placebo plus Abi and ADT. And the primary endpoint was radiographic progression-free survival, and there were several secondary endpoints, including overall survival. And what you see here basically when you look to the right-hand side, the HRR mutation subgroup, the benefit was clear in the overall subgroup to the triplet treatment with the niraparib being added. And you see the benefit also, significant benefit, more benefit, as you can imagine, in the patients who were BRCA subgroup. And so clearly they reported it, and this was published. The data was published again last year in Nature Medicine, that the study met its primary endpoint, showing that the niraparib plus Abi-Pred in combination with ADT improved radiographic progression-free survival significantly in both the BRCA mutated and the overall population. And so this was a very, very positive study. This is the data on the overall survival. You can see there is a trend. Obviously, the data is not mature yet. In the US, actually, right now, the FDA last year in December approved the combination of niraparib, Abi-Pred, and ADT in patients with specifically BRCA mutated patients who were castration sensitive. The other PARP pathway is a PARP1, which is saruparib, and this was actually reported at the ASCO GU symposium this year with Dr. Arun Azad, looking at saruparib plus ADT plus AR receptor inhibitor in patients with metastatic hormone-sensitive prostate cancer. This is the Patronha phase 1/2 clinical trial, and the design is listed here. And what you see here, basically, it was really very, very nicely designed clinical trial in that they looked at combination. They basically took patients who had a high volume disease. They evaluated the HRR mutation. The patients were randomized to get saruparib plus enza and ADT, saruparib plus abiraterone, prednisone, or saruparib plus darolutamide. And the primary endpoint was to assess the safety and tolerability, and there were several secondary endpoints. And what you see here is not surprising, is that what you see is responses seen across the board. But please remember, this is basically patients with metastatic hormone-sensitive disease, so you're likely to see a response. The question is going to be critically in the context of randomized phase 3 trials. Are we likely to see a response? So this is the EVO-PAR trial, which is a phase 3 randomized clinical trial that is enrolling patients with metastatic castration-sensitive prostate cancer. They had prospectively their tissue evaluated for HRR mutation, and they are required to receive androgen deprivation therapy, or they allow actually bilateral orchiectomy, and patients should have not had prior PARP inhibitors and so on. And the patients were stratified by the HRR mutation status, positive or negative, and then they are randomized to saruparib plus physician choice of AR pathway inhibitor versus placebo and physician choice of AR pathway inhibitor and ADT, obviously. The randomization is similar in both arms, and the trial radiographic progression-free survival and overall survival are the selected endpoints in both of the cohorts. This trial is ongoing, and we are hoping to hopefully in the next 2 to 3 years, we will hopefully hear the results. The other trial is the PSMA addition study, which was reported by Dr. Tagawa at the ESMO this past year, which evaluated lutetium PSMA in combination with androgen deprivation and AR pathway inhibitor in patients with metastatic hormone-sensitive prostate cancer who actually have PSMA positive disease based on PSMA imaging. This is the design of the study. So patients had to have untreated or minimally treated. Essentially, they could have started ADT, but not too long before. Good performance status. They had to have at least one or more positive PSMA lesions, and they were suitable for androgen deprivation and AR pathway inhibitor, and they were randomized 1-to-1 to the doublet with ADT and AR pathway inhibitor versus triplet with ADT, AR pathway inhibitor, and lutetium PSMA. The endpoint is radiographic progression-free survival, and crossover was actually allowed. And what you see here, the early report at the time at the ESMO clearly demonstrate an advantage in the triplet therapy with the lutetium PSMA, with a significant improvement in radiographic progression-free survival, or basically death without progression of disease in there. I think it'd be the data on overall survival. There are some trends favoring the triplet with lutetium PSMA. However, the data is not yet mature. As you can see, the median has not been reached. Now, one of the critical questions that I think is important is the issue in the era of we have very more effective intensified treatments. Do we have to continue treatments for life, or is there room to consider treatment holiday and then resume therapy if the disease progresses? So this is sort of like the same concept as we did with intermittent therapy, but looking at a little bit different strategy. So the ADREAM study is a cooperative group trial led by the Alliance, and when it enrolled patients with metastatic hormone-sensitive prostate cancer who achieved undetectable PSA less than 0.2 on androgen deprivation and AR pathway inhibitor, and at least about 1.5 to 2 years of treatment, but requiring at least 12 months of AR pathway inhibitor treatment. The patients will interrupt therapy, and then they get monitored with PSA and imaging, and then basically resume treatment based on disease progression. The primary endpoint of the study is actually treatment-free at 18 months with eugonadal testosterone. So this trial actually is fully accrued at this point, and we're hoping to hear the results hopefully soon. One of the questions also that was evaluated by the STAMPEDE is in patients who have de novo metastatic disease and the prostate is still there, is there an advantage in radiating the primary disease? And so the trial from the Stampede was reported by Dr. Clark several years ago, where basically they did patients who had androgen deprivation treatment, and then the experimental arm with radiotherapy to the primary. And what you see here overall, the overall survival for patients with low burden disease, low burden metastatic disease, by the Stampede definition, technically similar to the low volume disease, what you see there was an advantage in radiating the primary, whereas in the high volume or the high disease burden patient did not seem to be of benefit. Now, I want to point out that doesn't mean you could not radiate it if the patient is having symptoms. If they have, let's say, high volume or high metastatic burden, and they're having local disease symptoms that are persistent and don't seem to be responding from the androgen deprivation, this is a situation where I would certainly consider potential palliative radiation to the prostate, but not routinely for every patient. Now, we have come a very long way, and certainly the standard of care for patients with metastatic hormone-sensitive disease have significantly evolved since the 1980s. And so we've moved into the era. First, it used to be doublets, or first of all, was just basically gonadal suppression or castration. We've moved into the doublet and the triplet approach. And one of the critical parts is the key outstanding questions is when and for whom should we intensify treatment? What will the metastatic hormone sensitive landscape look like in the near future? And what is the impact of PSMA PET imaging in terms of decision? I want to point out that all the data on high volume, low volume, high risk, low risk disease is all based on conventional imaging, not PSMA PET imaging. So with all of this, we have published a paper in JAMA a couple of years ago on, from a recommendation perspective in terms of treatment approaches in metastatic hormone sensitive patients, taking into account the functionality of the patients, the frailty of the patient, are they healthy and fit? Are they vulnerable? Are they frail? The metastatic stage at diagnosis, are they de novo versus metachronous? Do they have high volume, low volume, and so on? And all of these data are in the paper, and the figure is in there. And critically, I think several decisions will have to be taken into account in the decision making. Now, one thing I want to end now, we really have come a long way since the original days of orchiectomy. This is data from several SWOG clinical trials to highlight how much improvement we've seen in the overall survival. And I would point out this is not including data with triplet therapy at this point. But basically, therapy intensification with doublet and triplet have significantly improved overall survival for men with metastatic hormone-sensitive prostate cancer. In the 80s and the 90s, median survival used to be 2.5 years. Now it's 6+ years there. Nadir PSA is a useful prognostic factor, an indicator of response and overall survival. One of the questions that we get asked a lot, and certainly in everyday practice, is critical: how best to choose which AR pathway doublet versus ADT plus docetaxel versus triplet. Critical consideration is age, performance status, safety, type of imaging that one is using, and I'm happy to answer questions about that. Comorbidities, as listed here, the volume of disease, is the disease de novo versus metachronous, and so on. Clearly, minimizing side effects and maintaining quality of life while prolonging survival are the key goals. Moving forward in 2026 and beyond, in the era of potent AR inhibitor, trials are needed to evaluate the role of docetaxel combination with ADT and AR pathway inhibitor, at least in patients with low volume disease. And I want to point out to you, we do not have trials addressing this specific question. Opportunities to consider is better imaging, which provides a window of opportunity to treat the cancer at an earlier stage, hopefully result in better outcomes. The role of targeted therapy in molecularly pre-selected patients newer pathways to consider. What about therapy de-intensification in long-term responders? When do you decide and how do you go about doing that? Efforts clearly to enhance durable response to systemic therapy is converting metastatic hormone sensitive from imminently deadly to potentially more chronic disease on our way, hopefully, to potential cure in some subsets of patients. I want to point out I have many men who are actually past the 6-7 years. Some of them are even 10 years out from when we started their treatment, and they continue to be in remission, which is really remarkable. I guess I always ask this question, are we there yet? No, but I do think we are getting much closer to impacting the outcomes of our patients. With that, I want to end, and photography is one of my hobbies, and these are the views from Lake Michigan, both the Michigan side and the Chicago side. Thank you.
Yes, thank you, Professor Hussain, for enlightening us with overall aspect from the MHSPC treatment perspective. I would request Dr. Amit Joshi sir to take the Q&A and involving Dr. Dattatreya as well as Dr. Hussain.
Yeah, thank you, Dr. Hussain, for a wonderful talk. So there are some questions which are pertaining to our Indian context. So I would like to involve Dr. Dattatreya and you also. So the first question is to Dr. Dattatreya: how do the epidemiological features of Indian MHSPC patient, earlier age at diagnosis, higher disease burden, and delayed presentation differ from Western world, and how should these differences shape our treatment approach? So, to Dr. Dattatreya, how our patient different from Western world, and how we should take it in the management of these patients?
Yeah, sir, a very apt question. Our patients are more younger. Our patients have more de novo metastatic disease. And that's the principal reason why we also end up getting more advanced stage patients because of screening not happening. So I think if this has to be tackled, most important would be to engage in a nationwide awareness program and involve the PSA screening. That possibly goes a long way. And then we'll be able to incorporate all the regimens and advances which Madam spoke to all of us.
I want to ask a question, actually. Is this, you think, biological potentially, or is it because of lack of access to care? So, if patients are not being evaluated, they're not getting, physical exams on a regular basis, PSA checks, and things like that. By default, prostate cancer is the most common cancer in men worldwide, and so obviously they will likely to present with de novo metastatic disease. So I'm wondering if you see it like in rural areas, well-to-do people versus cities versus poor people, all of that. It may be a factor. And I think this would be a great project to investigate.
Yeah. So I think what I can say from my experience that now in last 4 or 5 years we are seeing much younger patient compared to the previous. So in our day-to-day OPD, at least we see one or two patient which is less than
Okay.
55 years in a prostate cancer. So I personally feel that like in a triple negative breast cancer, the incidence of a TNBC in Indian scenario is 1 decade earlier. I personally feel that there may be a different biology in our Indian patients compared to the Western. And in the same line, we are working on a project with the our epidemiological department to look into the genomic profile of a Indian patient less than 55 versus is there any difference? So we have written that and we have submitted for a grant. So I personally feel there is some difference. I think I want to take the Dattatraya's experience in this context and his opinion about this. Do we really see more younger patients than the Western population?
So maybe I can make just a quick
Yeah.
comment. I
Yeah,
actually
yeah,
have,
sure.
yeah, sorry to interrupt, but I have actually a project, Prostate Cancer Foundation funded project, because I actually am began to see, I want to say the last probably 10 years, younger men, literally, my youngest patient was 37 years old. It just so happened to be he had an Indian heritage. His family had moved to Chicago, and he was born in Chicago. And so, but I also have like whites and blacks and other races. And so this project, we have completed accrual and we're analyzing the data. And one of the things we're looking at is genomics and germline and obviously environmental exposure and other factors. So I find this is very interesting, and I think this would be a great project, definitely.
Yeah, I think you are absolutely spot on this. Dattatreya, what's your opinion about this?
Yeah, I completely agree. We are seeing more and more younger patients when compared to the Western population. It's we see. Yes. Now, I also add complete concurrent
Dattatreya,
manner
your I
that
think connection
it's
is, we are not able to hear properly. I think there is some
biologically. Is it okay now?
little bit better.
Is it okay now?
Yes.
Okay, so at this, maybe biologically there is something wrong in the genomic.
You can switch off your video.
Dattatreya, you can switch off the
Yeah.
video. I think then the
Is
audio
the
may be
video
better.
switched? It's better now.
Yeah.
It's better now.
Yes.
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 So essentially, maybe the disease biology is different.
Yeah.
That's what we are.
Yeah.
So in the same context, but that were the question. Second question is that out of say 10 patient of HS of a prostate, how many are the de novo metastatic in your setting?
Yeah.
Approximately 7 to 8 of them are de novo in the Indian context in my clinical oncology practice, which I think
Yes.
is in stark contrast to the Western, let's say.
And Dr. Hussain, what's in your clinical practice? So if you see Monday morning the 10 patient in a prostate of a prostate cancer coming to your OPD, how many are de novo metastatic?
Dr. Joshi, part of the issue here is because I get the referrals. So,
Okay.
I'm saying, like, I'm not a general oncology practice, so invariably it's the patients
Referral,
who get
yes.
referred to see me. I would say probably 30% on average are de novo metastatic disease, or slightly more. Although I began seeing more of those literally, again, as I said, over the past 10, 15 years, which is really what prompted us to do the project, the PCF funded project to look into why this is happening. Now, fascinating, the bulk of these patients are not poor. They have been evaluated. So it's not like socioeconomic factors. They live in the cities generally, and the other part would be there seems to be also a strong family history. So I do think, and this is not just family history as it relates to prostate cancer, which is why when we evaluate and to the audience, definitely any patient who have, of course, family history of prostate cancer, they should undergo germline testing. But definitely, the guidelines have shifted. Now, patients who have breast cancer, family history of breast cancer, or ovarian cancer, definitely consider also germline testing, and then counseling their blood relatives, first and second degree blood relatives on early detection. I don't know what the healthcare policies in India is, but definitely early detection for breast cancer, prostate cancer becomes important.
So I think in due course of time we have realized, and now it's practically at this I work in an academic institute. So all metastatic cancer patient, even in HSPC setting, we send them for the somatic and germline mutation.
Sure.
And we have
Yeah,
fortunately we have a dedicated genetic clinic. So we refer them, and then the genetic team the clinic
sure.
take over. So I think it's a
Good.
very valid point that we should ask and we should refer so that we can
Yeah,
detect the early one. So the
yeah.
third question in this context is in the context of an aeronaut study that has demonstrated of efficacy of DARA plus ADT, how does its patient population compare to the typical patient you treat? And can we confidently extrapolate these finding? A quick answer from Madam in in this. Can we extrapolate the darolutamide in our day-to-day setting compared to the clinical trial setting? So how confident with this RNA data?
Well, I think it's obviously, it clearly shows advantage. One thing I want to point out is that when we look at all the trials, going all the way back to the days of flutamide, combined androgen deprivation has an advantage, no question about it. And so I would say right now, it's been decades since I have not used an AR inhibitor. We started with flutamide, then bicalutamide, then of course AbbVie, then the rest of them came in. So I would say definitely. Now, one of the factors to consider, again, if you're choosing a doublet for treatment, when it comes to the choice of the AR inhibitor, obviously go with the strongest drugs, the more modern AR inhibitors. I wouldn't go with the old days flutamide, bicalutamide, unless you have issues of access or not able to get it or cost factors. But definitely, I would say looking into the drug-drug interaction, the safety, patients who have cardiovascular risks, seizure risks, things like that would favor you choosing the darolutamide for sure, because it's generally better tolerated. And so I think that from that perspective, and if you're going to choose triplet treatment, I generally would favor Daro, because when you go with AbbVie, you have to use prednisone. There's the issue of electrolytes and all of that factor. But if you don't have access to it, then definitely for a while we used the triplet with AbbVie.
And what about this favorable CNS safety profile? And so, as discussed, majority of the patients are elderly and they have age-related issues. They are already on the other
Yeah.
medication related to that. And
Right.
the other important factor, which is when I discuss with residents, when we discuss about the ARPI, that these patients are already, because of the age, they are osteoporotic. With the ADT, we are making them more osteoporotic. We are giving them enzalutamide. Sometime even a trivial trauma, little bit for the cognitive dysfunction, the risk of fall, even a trivial trauma can result in a fracture of the bone,
Yeah.
which was seen in these studies. So what about your opinion regarding the favorable CNS profile, and how important in day-to-day setting when we treat these kind of the patients?
Yeah, I think it's a function, as you point out, to the patient functionality, what drug was going to likely to give them lesser risks, the different risks. I would say in older patients, there's no question from my end, I favor darolutamide there. In the younger patient population, it's a little bit different. You have different choices. So for us in the US, it's all going to be driven by also access to the drugs and the cost, because with us, generally, there's insurance and there can be a significant copay factor. So that's another thing that would work. And then, of course, always work with your pharmacist on the drug-drug interactions, because majority of patients are going to have either hypertension, diabetes, other health issues. So there will be the drug-drug interaction factor that's going to be a critical thing. But I would say overall, darolutamide is a much easier to use for patients, and it's very effective.
So the next question to Dr. Dattatreya, that when we plan for a triplet therapy, what patient profile you want to really, in at least from the Indian perspective, which patient do you really want to give the triplet in a high volume, and in which patient you want to avoid, even if it is a high volume MHSPC? And then madam, so in Indian context, the selection of a fit patient for a triplet versus patient who can't tolerate the triplet, how you decide?
So I think it boils down to two things essentially. Is the patient having a good performance status? And number two, do I judgment the patient will be able to satisfied, then I don't see any
I think there is, I think,
problem
Dattatreya, you have to change
and
your
all the
position in the home.
applications.
The connection is a problem. Yeah.
Connection is a
Yeah.
problem. I think you come to the your
Okay,
main room. I
okay.
think that may be.
So yeah, so essentially, I would look at two things. One is the patient's performance status, and the second
Yes.
is, in my judgment, do I think can the patient take docetaxel? If these two things are answered, which is something we do very common in clinical oncology practice, and then some patients are fit for zero problem, minimal problem. So it all boils down to docetaxel.
So, but the same question to the madam, that how comfortable or how useful is to go for a geriatric assessment tool in deciding, and do you think that same tool maybe in our patient population, the same tool can be applicable, or we have to devise some other which is pertinent to our Indian patient population? So do you really use the geriatric assessment tools for deciding the docetaxel based fitness chemotherapy? in a high volume metastatic prostate cancer?
So I generally would use I don't necessarily use the geriatrics tool. It's more of what I say, anytime you think you're going to cause harm, don't use it. Now, the other factor is the age of the patients, because I can imagine you must see patients in in their late 80s and so on. Literally, I just saw a patient who were 96 with metastatic disease, just de novo. So my guess is he probably had it for decades.
Yes.
It just popped up
Yes.
right now. Yeah. So I think you have to balance risks and benefits. And I would
Yes.
say generally patients who are, we have actually in the US what we call the Social Security table that allow you to forecast what is the odds of this patient living 10 years
Surviving.
or more,
Yes.
and based
Okay.
on comorbidities and other things. So anytime you do that and the patient has an excellent odd of living more than 5 years, these are the patients that I would favor going with triplet, assuming it's safe. Now, there are times where patients could have been diagnosed 7, 8 years ago with with prostate cancer, and it wasn't until 7, 8 years later they popped up with metastatic disease and they are very low volume. These patients, we go through the discussion. I generally go with doublet treatment. Although I counsel them, and it's a shared decision ultimately. But again,
So,
if,
so
as you know, right now we're using PSMA PET, and you
yes.
see 2 lymph nodes retroperitoneal, and that's it, and they're small and just lighting up. It's like to go with chemo triplet. It just seems like too much to do.
Too
Now, these
much.
are the
So
kind of patients where we treat them and then consider, radiating because they're low volume,
prostate,
the site
low
of disease.
volume.
Yeah, yeah.
Yes. So the next question is, when you discuss about the high volume versus low volume, so how the counseling differ when you talk to about triplet the Aranat versus Arasense. So what parameters you want to discuss in a fitter patient, 65-year-old male, you want to discuss about doublet versus triplet in a high volume. So what are the points you want to highlight when you talk to the patient and their family?
Yeah, so basically, clearly, in the high volume patients have worse prognosis than the low volume patients, and especially if they were de novo high volume. I mean, that tells you the disease is bad and aggressive. In those patients, I generally favor triplet treatment. I also discuss with them that if they don't want chemo, then we can fall down to doublet treatment with, the either Daro or any of the AR inhibitors. But generally speaking, my recommendation is triplet. And I have to say, almost 99% of patients actually agree. Yeah, yeah.
Okay.
And there's no decision that has to be made immediately. This is, you see them, you counsel them, you start the treatment.
Um,
And that's why with all the trials that looked at triplet, there was a window to starting the chemo. It
treatments.
doesn't have to be started the first day. Yeah, yeah. But don't
Yeah.
delay
So I
it too long either. I'd say within the first 3 to 4 months is when to start, and I wouldn't delay it longer than that.
So that what we do, usually start the EDT plus ARPI, and then call
Yes,
the, by the time the patient general condition also improves. Some patient may have a multiple metastatic disease, they
yes,
respond to the ARPI, and their
yeah,
tolerance or readiness to take the chemotherapy will be better when they are
yes,
clinically improved, rather than on day one if you talk to them
yes, yes,
for the chemotherapy. That what we
absolutely.
have realized over a period of time. So
Yeah.
the other question, or the common thing, which at least India is known to be the capital for the cardiovascular disease, diabetic and all that. So in this context, how meaningful is the darolutamide reduces the risk of interaction with the statin and steroid related to abiraterone and other ARPI? So in the context of the cardiovascular disease and metabolic disorder with polypharmacy, how does the darolutamide scores over the abiraterone and the ENJA? That is the question from my side.
Darrow generally has a lesser issue of interaction compared to, say, Enza, for example. But I would say this is the advantage we have, and this is something for you to consider making sure it happens. We have actually a pharmacist in the clinic with us. Every clinic,
Oh,
there's a pharmacist sitting with us. And so basically, I don't go and decide myself. Once I discuss with the patient the potential choices based on what I think is reasonable, we go back to the pharmacist and look into the drug-drug interactions. There are situations where we also have seen the concern with drug-drug interaction with the darolutamide also, but much less than other agents. Yeah.
and Dr. Dattatreya is there still? I think he
I think so.
had,
has some issues, technical issues.
Okay. So we'll continue our discussion, and then the next most important question of this evening, that the choice of the comparison between the ARRowNet, ARRowSense, ENJAMET, and Titan. So the other ARPI, the ENJA versus aplutamide versus darolutamide. So what are the points which we have already discussed, but still the any situation where you want to avoid darolutamide, or there is any scoring or any benefit of these ARPI, or darolutamide is the winner in all these scenarios? What's your take call on that?
I think ultimately, as I said, for us in the US, is all driven by if you think it's safe, any of these drugs are safe, then I usually will actually, and I check with my pharmacist to make sure, because the majority of the patients are on some medication, for
Yes.
different other comorbidities. And so basically, if I think it's safe to give them any of these drugs, I usually will actually give them information on them, and ultimately it's a shared decision with the patient.
So with the current available data, I think safety of this darolutamide is clearly over the
Yes,
enzalutamide, and
yes,
definitely over the
absolutely.
abiraterone. There
Yes,
is no doubt.
yes, yeah,
Since there
yeah.
are no head-to-hand trial, we can't say that whether one is, but we can indirectly
Yes,
compare
yeah.
that. So I think
Yeah.
that.
Yeah, no, there's no trial to compare the efficacy of these drugs, but when you look at the survival curves compared to the control arms and everything else, there's no question. Now, I would remind you that the trials that were done looking at a control arm of giving only ADT, this is pretty much historic arms because
Yes.
no longer anybody is just ADT. But all these trials were done looking at there. Ideally, I would say the cooperative groups, and I don't know if you have a national group in India, this would be a great opportunity to do a randomized trial with patients who have metastatic disease. And then if you really want to kind of look, is one drug better than the other, safer than the others, and so on, we do need the trials, no question about it. Yeah. But I think we're not, I don't think this is ever going to happen. And so I would say you'd have to use your judgment and what is
Yes.
best for the patient.
Yes.
Yeah. And that's, as
So
I said, why I give them information. And a good chunk of time, for example, a good number of the patients who, let's say, either de novo or metachronous metastatic disease, if you're going to go with ADT, again, I don't know if you have the relugolix,
yeah,
the
it's
orthobig
available.
yeah, available. Because in reality, in the older days, what we did is we gave them AR inhibitor like flutamide, bicalutamide to block the AR and then go with injection with the LHRH treatment. Now that we have the drugs that can suppress testosterone, I usually will do a lead in with those agents first, just to get the process going. And then a good number of times, actually, the patients opt for injections, believe it or not. They prefer to go with Lupron or, Eligard or
Yeah.
something.
And the other question which is relevant, that in the context of a relagolics, the drug-drug interaction of a relagolics with these newer ARP, that is also
Yeah.
need not been studied. The relagolics
Yeah.
was mostly
Yeah.
studied in terms of the locally advanced, not in the
Yes.
combination. So I
Yeah.
generally do not prefer. I give them the option. I don't give the combination. We
Yeah.
consider gene as agonist or antagonist.
Yeah.
So I think there are two or three quick questions with since I got an opportunity to talk to you. So, like in Indian context, we rarely do a CT scan and bone scan, since the availability of PSMA PET is very easily available at the cost of a CT scan and bone scan. Probably the PSMA PET may be cheaper. So, do you think that doing a PSMA PET might be the how it will influence the current management in our scenario? Are we picking the or changing the treatment early just based on a PSMA scan? In the same context, if the CT scan and bone scan has done, they might not have picked the disease. So what's your thought, and how we should integrate the PSMA PET CT in our clinical scenario? Because whatever we discuss, we will going to get the PSMA PET in day-to-day
Yes,
setting.
yes. No, I know we have the same drama, but I generally try to verify. The one thing I would say, and we published a case report. You might want to look at. I believe in JAMA Oncology. I believe I'm happy to share it with you guys later if you want to. The fact that we have the PSMA scan and it's supposed to be more sensitive and all of that, just remember, none of these radioligand, radio agents NucMed scans are 100% specific. They are
Yes.
sensitive, but they may not be specific. And so I've had situations where if I have time, I can tell you a few case scenarios, but I'll make them brief. One of them is a gentleman who was a runner. In the summertime, there is running that happens across the lake area. And he basically did not want to start. He had a rising PSA. They did a PSMA PET on him. There was lighting up areas in the retroperitoneal lymph nodes. And so they sent him to see me for metastatic disease. And the guy basically was asymptomatic, feeling great, and was going to run the marathon. And so did not want to go on hormone treatment until he's done with the marathon. Well, he did the marathon. He had a trip to go out of the country. And before you know it, it was 2 months since I had seen him, so I repeated the scan, and and then what happened is basically the scan, whatever lit up on the previous scan, went away. So the point here is you can't just go by what if there is like just stuff lighting up. You need to verify if this is real disease. Another case scenario that I have seen was a situation where the patient had actually lung lesion. And as you know, lung mets can happen in
Mm.
prostate cancer, but it's not like there is nothing, the patient, yes, is high risk, but there's nothing showing up aside from lighting up in a lung nodule. And when I biopsied, and I had several cases, turned out to be lung cancer. So here,
Yeah.
what I'm saying is use
Yes.
your clinical
We had a
judgment
similar
to verify
experience. Yeah.
exactly
Yeah.
to verify what you're dealing with and
Yeah. So,
treat accordingly.
so
And there
what I
are
tell my
times,
resident, yeah, keep
pardon?
whatever lights up in the PSMA PET is not always the prostate. It may be sometimes
Exactly,
you have to
is
do the
exactly.
clinical
And
experience.
sometimes it goes away, it's kind of inflammatory. So I think you have to use your judgment regarding that and then properly treat, the patient.
So for a few months back, we had a chance to hear Dr. Neeraj Agarwal, who is I am very close to him. So
Yes.
and in his talk, he just mentioned about the use of SPOP mutation in the management of this, and in some patients with this SPOP mutation, we can de-escalate even in high volume. And in India, we have a facility of getting NGS at a very cheap rate. So, what's your take on call the SPOP mutation? Can we do selectively, not at a trial, but on a patient basis? Can we safely rely on the SPOP mutation? So, high volume SPOP mutation, use hold the docetaxel, continue and use the docetaxel later on. What's your take on call this?
No, no.
No, at this point of time, we
Convince
should.
me. You have to prove it first.
Yes, so we have to. And
Yeah.
have you changed your practice from in a high volume the triplet Arasafe to the Arasense to Arasafe? Do you commonly use the 2 weekly regime then the 3 weekly in high volume the Arasafe data, or you are
No,
still three
no,
weekly?
no. Yeah, no, I have not.
So you are
Yeah,
still continuing with three weekly. In our
yeah.
Indian context, since the patient sometime, so we are using a 2 weekly. We find it more patient friendly in terms of the FN neutropenia and all that is. So we are using commonly the ERA safe regime at this point of time.
Yeah, no, I stay with when you look at the data with the triplet, whether the Abbey or whatever, it's the every 3 week schedule. And the other part would be for us, we have the ability to use growth factors. So that would help as it relates to the blood count.
Thank you very much, Dr. Hussain, and it was very wonderful to talk to you in this. And I have a lot of questions when we meet in person. Then definitely I will ask a lot of questions regarding this.
Well,
And
thank you
I think
very
I will.
much, Dr. Joshi.
Thank,
Yes.
thank you,
Yes.
and Dr. Amit to take over from further.
Yes, yes. Thank you, Dr. Joshi sir, for means moderating as well as you are giving Indian perspective overall across India and comparing with the global benchmark. So I also would like to thank you, Dr. Dattatray, for his session. We sincerely thank Professor Mahausen ma'am for her insightful and thought-provoking session on prostate cancer and sharing global perspective as well as the her clinical insights so that we can our Indian clinicians can implement the insights from the global perspective. And we would like to have such interactions in coming future. Thank you once again. Have a great weekend.
Thank you very
Thank you
much. And
all.
thank you, Dr.
Thank you.
Jadhav and the
Thank you.
team, Dr. Joshi, for the invitation. It was
Thank
my
you.
pleasure.
Thank
Thank
you.
you.
Thank
And
you.
I guess
Thank you.
good night for you.
Yeah,
Yes,
it's good
thank
night
you.
for us. Thank you.
And we extend all heartfelt appreciations to all participants who are joined virtually to listen this program. Thank you.
Thank you.
Thank you.
Bye-bye.
Bye. Bye.
We can stop.